This liver overcompensation causes marked hyperlipidemia. It's a perfect, tragic domino effect.
Part 4. The Clinical Showdown.
So, we have the angry, inflamed kidney on one side and the leaky, busted sieve on the other. Now it's time for a rapid-fire bedside comparison. Let's start with swelling, or edema. In our nephritic patient, the edema is pretty mild to moderate. You'll classically see it periorbitally, so around the eyes, especially in the morning when the patient first wakes up. But look at the nephrotic patient. Because they've lost all that albumin, they've completely lost the oncotic pressure that normally holds fluid inside their blood vessels. The result? Severe, generalized, full-body edema, which is known clinically as anasarca.
Next up, blood and pressure. Remember our golden rule from earlier? Inflammation drives bleeding and pressure. So in nephritic syndrome, hematuria is prominent, and hypertension is super common because of that fluid retention. In stark contrast, our leaky nephrotic patient usually has absent or only microscopic hematuria, and their blood pressure? It might be completely normal or just mildly elevated. So at the bedside, the distinction is really crystal clear.
Let's move to the urinalysis showdown and see how this builds on everything we've discussed so far. You send off the urine. The nephritic sample comes back looking like a microscopic battlefield. You've got red blood cells, RBC casts from those damaged capillaries, and only mild proteinuria. The nephrotic sample, though, comes back completely different. It is totally dominated by heavy proteinuria, and something entirely unique, fatty casts.
That brings us to a massive, super high-yield clinical buzzword you have to know, lipiduria. Because the liver is overcompensating and flooding the blood with lipids, those lipids actually spill right into the urine, and under a polarized microscope, these lipids appear as Maltese crosses. If you ever see fatty casts or Maltese crosses on a lab report, it absolutely guarantees a nephrotic diagnosis. You will never ever see this in nephritic syndrome.
Part 5. Your diagnostic pearls.
We've covered the microscopic damage, the domino effects, and the bedside showdown. So the crucial point is, here is your ultimate diagnostic cheat sheet, derived straight from our framework. If you suspect nephritic syndrome, your absolute key feature is hematuria with RBC casts. It's the smoking gun that proves inflammation and capillary damage. But if you suspect nephrotic syndrome, you are looking for that classic clinical triad: massive proteinuria, which leads to hypoalbuminemia, resulting in generalized edema.
And that brings us to the end of our ward round explainer. You now have the master matrix decoded. So, the next time you walk into a hospital room and see a patient with severe swelling, abnormal urine, and failing kidneys, ask yourself, is it inflamed or is it leaking? Will you know exactly what their glomerulus is doing? Keep these patterns locked in, and you absolutely will.